me, see me, and see my slides?
Yes.
All right. Good afternoon, everyone. Thank you all for being here today. We're here for our January NCE, which is Human Trafficking in Healthcare. So today we're just going to be talking a little bit about just the general dynamics of human trafficking, how that shows up in healthcare, and what healthcare providers can do to provide support to patients who've experienced human trafficking. We invite you all today to come off mute. I'm going to be asking some questions. If you want to have your camera on, we ask you to turn your camera on, just interact with us. It's going to be a little bit of an interactive presentation today, just so I'm not sitting here talking to you all the whole time. Also, before we get into today's presentation, we just want to give a brief content warning. We will be talking about some tough issues. So just a reminder to take care of yourself. And if you need a break, we completely understand. We ask that if you need a break, you just remove yourself, have a drink of water, turn your camera off, and do whatever you need to do to nourish yourself in that moment. If you feel as though you need additional support, we do have a confidential text line that you can text. The number's at the bottom of the screen, but that number is 973-972-4636. And if at any time anyone needs that number, I can put that number in the chat. So we're going to start off with our general definitions. What is human trafficking and who is victimized? So we broke down the definition of human trafficking into the action, means, and purpose model. So human trafficking involves the recruitment, transportation, transferring, harboring, or providing or receiving of persons. How human trafficking occurs is through the threat or the use of force, coercion, abduction, fraud, or deception. And then why? Human trafficking occurs for the purpose of exploitation, commercial sex acts, and forced labor. Human trafficking is also further broken down into sex trafficking and labor trafficking. So when we talk about human trafficking, we want to talk about it more broadly as a public health issue. So human trafficking is a public health issue that impacts individuals, families, and communities. Traffickers of human trafficking disproportionately target at-risk individuals. This may be individuals who have had prior experiences with violence or individuals who are disconnected from stable support networks. Some common marginalized communities that human trafficking affects tend to be Native Americans, Native Hawaiians, and Pacific Islanders, those of the LGBTQ community, undocumented immigrants, racial and ethnic minorities, people with disabilities, and people with low income. There are some more at-risk communities, and these at-risk communities involve victims of childhood abuse or neglect, children involved in the foster care or juvenile system, or runaways and homeless youth. These are some at-risk communities because it's easier for traffickers to come in and assert power over the victim. In this video, I'm just going to play a brief news clip about human trafficking and how it occurs in healthcare.
Well, more than 60.
Can you all hear the video?
8% of trafficking victims are seen at an emergency department, and that is why healthcare workers are vital partners in the fight against human trafficking. And as we found out, a person's life expectancy can actually be impacted by the treatment they receive when they finally seek care.
Some studies saying like you lose 20 years on your lifespan without appropriate intervention and support through these traumatic events.
Emily Huggins is the manager of the Forensic Examiner program at Wellspend York Hospital. The program began in 1988 and has really grown since the early 2000s.
Abuse and trauma is a root cause of health disparity. Yeah. So we wanted to try to do better.
And they have, with many updates being made to the unit over the years with domestic violence and human trafficking victims in mind.
We need to first realize that these things happen. We need to recognize when we're seeing the signs in our patients, and we need to react in a way that isn't going to re-traumatize the patient.
That includes offering victims a safe and secure space here in the Forensic Examiner suite, away from the chaotic emergency department. Staff is
So I'll just take a brief pause there just to ask a question. My question is, why do you think that healthcare providers may be the first or only contact with human trafficking survivors? And you all can put that in the chat, or you can come off mute and answer.
Do you mind repeating the question?
Yeah, no problem. The question was, why do you think that healthcare providers may be the first or only contact that human trafficker survivors interact with?
I can take a shot. I'm not really too sure, but like maybe just from guessing that they're afraid to kind of go to anyone else for help. And if a medical emergency or something comes up, they have to see a healthcare provider. So that person may be the only person that they interact with besides, you know, their perpetrator. Maybe because they have to, like in terms of their health. So maybe for that reason.
Yeah, that's completely correct. So oftentimes, hey Carrie, oftentimes when a person is being trafficked, if a health emergency presents itself, that may be the only time that they have away from their abuser, the only time and the only opportunity for intervention, which is why that brief moment of intervention with the healthcare provider is extremely important. So why does it matter? We just watched a video about how the healthcare provider may be the first and only person that a human trafficking survivor comes into contact with. You also might be the only person who has the opportunity to speak with them alone. As a healthcare provider, you have that right to kind of ask to speak to your patient privately. So you may have that opportunity for intervention that others may not. Also, 28% of trafficked women saw a healthcare professional while they were still in captivity. This is a very significant percentage and just missed opportunity for intervention, as 28% of women are reporting that they saw a healthcare provider, which meant that there was room for intervention while they were still in captivity. Another reason that we felt that it was important was because 95% of emergency medicine professionals, which would be the most likely healthcare professionals who are seeing human trafficking victims, reported that they had never received any formal training on the appropriate treatment of human trafficking professionals. So in this clip, we're going to play a brief scenario of a human trafficking survivor and a healthcare professional. And then when we're done with the video, I'm going to pause for some questions.
Hello, my name is Joe Alvarado, and I'm the Senior Director of Clinical Operations for Trusted Medical. I would like to thank you for taking the time to learn about a very important public health problem, human trafficking. Human trafficking is the practice of modern-day slavery that is not just occurring in countries on the other side of the world. It's a major public health problem that is taking place in the United States, in our own hometown, in our own neighborhoods. This educational video is made to help increase the awareness of human trafficking in our emergency department, as well as to provide healthcare providers such as you education to help increase your competence and your ability to help recognize, correctly treat, and report potential victims of human trafficking. This video is a very likely case scenario that could happen in any one of our emergency departments.
Welcome to Trusted ER. How can I help you guys today?
Yes, we need to see a doctor. My daughter's feeling pain.
All right, that'll be no issue. If I can get an ID and insurance card from you guys, I'll get you checked in. How old are you?
She's 18. We're going to pay cash. Here's my ID. You can use this.
All right, that'll work for now. If I can just get you to fill out these forms for me, there's no rush on those. We can grab them by the end of the visit, and somebody will be with you shortly.
Destiny, I'm your nurse today. We can go ahead and get you back to the back. You can follow me.
No, leave that there.
So all of our snacks and drinks are for the patient, so I can go ahead and grab you something after your doctor sees you.
She's fine.
Okay. Okay, Destiny, what brings you in today?
She's having some stomach pain.
Okay. Can you show me on your stomach where it hurts? All right.
Sorry about that. That just went off.
Hello, my name is
Standard for all our female patients, even if they're not. 2002, is that correct? All right. When was your last menstrual cycle?
Like 3 weeks ago.
Okay. And then can you remember your very first menstrual cycle when that was?
Sure of the date, but I was about 13.
Okay. I have here that your birthday is 4/12/2002. Is that correct?
Yeah.
Okay. Well, we're gonna go ahead and get a urine sample. So what I'm gonna do is have you follow me to the bathroom while I go get the physician.
Oh, wait a minute. Why do we need a urine sample?
Well, it's just standard for all our female patients, even if they're not pregnant, because we need to make sure that there's nothing else going on.
I see.
Okay? If you'll follow me, we'll go ahead and get you set up. I know some of these questions can get uncomfortable, so we can ask your mom to step out of the room since you're 18 if you'd like.
It's fine.
Okay. Well, here you go.
So what's going on with our patient?
Well, she's an 18-year-old female with some lower abdominal pain. She's not currently menstruating, but something does seem a little bit off. She doesn't look like she's 18 at all, and the registration told me that whenever she checked in, she didn't have an ID, so they scanned mom's, but mom's last name's different. We do have a urine analysis if you want to look at it.
Okay. Well, she's not pregnant. However, she does have a UTI and possible STI. I'm going to need to do a pelvic exam. So when you go in the room to get her prepped, you can have her mom step out and wait in the lobby.
Okay, I can do that. Thanks.
Thank you.
Okay, Destiny, we're going to need to do a pelvic exam. So I'm going to need you to get undressed and then put on this gown. The part that opens goes in the back.
Hold on, wait a minute. Why does she need a public exam?
Well, her urine showed that she has a UTI, so the doctor wanted to rule out some other possibilities. It's probably best that we give her some privacy so that she can get changed.
No, she doesn't need. Why does she need a pelvic exam? She's here for stomach pain. I want to see a doctor.
Oh, okay, I'll get her.
Hi, Destiny. I'm Dr. Williams. I'll be taking care of you today. So as the nurse explained, we're going to need to do a pelvic exam.
Wait. Why do we need a pelvic exam?
So we did a urinalysis, and her urinalysis shows that she has a urinary tract infection. And in order for us to be thorough, we need to make sure that she doesn't have anything else serious going on.
But I don't understand. She came here for stomach pain. I don't understand why she needs a pelvic exam.
We just really need to be thorough. So I'm going to have you step outside to give her some privacy while we do the exam, okay? There's a TV, there's snacks.
That's fine.
Make yourself comfortable.
That's fine.
All right, Destiny, we're going to start the exam, okay? I'm going to listen to your lungs. If you could move your hair back, please. Thank you. All right, good. I'm going to lean you back now. Oh, wow. Destiny, how did you get these bruises?
I don't know. Work.
Okay, Destiny, I just want you to know that you are safe here, okay? Anything that is said in this room is confidential between you and me. Your mom does not need to know. Now, what work do you do to cause these bruises?
Well, I work with my mom.
Destiny, I want you to know that you can trust me and be honest with me. So how many years has it been since your first period?
About 2 years.
Well, according to my notes, I see that you were 13 when you had your first period. Are you saying that was 2 years ago? Destiny, are you 15?
Yes.
Destiny, at work, do they require you to perform sex acts? All right, Destiny, you have not done anything wrong, okay? This is not your fault. We are going to get the medical attention that you need. You are safe here, okay, Destiny? What's going on is illegal, and I am going to have to call the police. But it's not that you did anything wrong. You are not in trouble. Because you are a minor, I'm obligated to call the police. There are some people that have experienced the same things that you're going through right now. Would you like to talk to them?
Yeah, I guess.
Okay. Hey, where'd she go?
I'm not too sure. She just took off.
Okay.
I hope this educational video helped to increase your awareness and ability to recognize a potential victim of human trafficking. Studies have shown that 88% of victims seek a healthcare provider during their captivity. 63% of those sought healthcare in the emergency room setting. This places the emergency room staff in a unique situation to intervene. For the victim, this encounter is a critical opportunity for life-saving support or perhaps even rescue. The National Human Trafficking Resource Center operates a toll-free hotline that's available to answer calls on human trafficking 24 hours a day, 7 days a week, and over 100 languages. That number is 1-888-373-8888.
Okay, we'll pause there. After viewing that questions, I just want to ask, how does everyone feel after viewing that video and viewing that scenario? Carrie, can you assist me with reading the chat box?
Yep, I'll be in the chat, and I also encourage people to unmute and show your faces if you're in the comfortable space to do so.
We also want to ask, what are some of the red flags that you noticed throughout the interaction with the healthcare provider?
Something I was noticing was kind of like not, especially in this setting, because it's like a minor, but sometimes it's hard to discern because the mom was talking for her and like kind of like speaking on her behalf, which it was a red flag because I know she was very quiet, but like sometimes like the parents do speak on the children's behalf, so it could get a little like, are they in trouble or are they just kind of shy and their parents are speaking for them? So that's something I thought about. And I think there was something in the chat.
Yeah, I definitely like that you brought that up, because that could be a great area where you're kind of looking at the situation and you don't exactly know how to read it. Is this a red flag that something else is going on, or is this just a shy child? That's why we're going to talk about a little bit about some more signs and some questions that we can ask to get to this point of intervention.
And sometimes we call those things yellow flags, right? It could be something, it might not be something. And so there's maybe some more time for evaluation. Daniel also added in the chat that tattoo on the back of the patient's neck, looking down, just the overall body language of that patient.
And I think that's another great point. I see in the chat that questionable age got brought up, and we're going to talk a little bit more about both of these things later. We're going to talk about examining body language and just common discrepancies that a healthcare provider might see. Like we saw the scene where the mom said she was 18, but when the doctor asked her about her age, in reality, she was 15. Was there anything in this interaction that we thought that the healthcare provider did well, or anything that if we were in the healthcare provider's shoes, we would have changed?
Definitely isolating the patient from, whoever's there with them. So you have the privacy to ask them more questions. Was done well.
I think also at the end, when the doctor was saying like there are other people who have been through this as well, I think a lot of victims like feel very alone, which is why they have a hard time opening up even when they are alone with the healthcare provider. So by saying that there were other people going through it who have been through that and made it out of that, I feel like that's like really reassuring.
I see in the chat after the revelation, maybe she shouldn't have left the patient alone because running away is a high possibility. That's a very, very good point. As I watched the video, I think that there was a variety of things that I felt the healthcare provider did well. One was when they noticed the yellow flags, as Carrie pointed out, the separation of the mother in the video from the child. And then I thought that they did a good job of guiding them through the interaction, letting them know why they were asking certain questions and how they were going to ask them. I thought the healthcare providers did that well. And to comment on the most recent and comment in the chat of they shouldn't have left the patient alone, that was a really good point. And I think that in the scene when they went to call for the referral, maybe they could have waited until the referral person came before leaving the patient alone, maybe contacting an advocate or a support person to come sit with the patient before leaving the patient alone, or even having the nurse come in the room to sit and talk with the patient.
I would also add that language matters, right? So when at one point the doctor said, this is confidential, and then the next moment the doctor said, I'm going to be calling the police, right? So we've now lost that sense of confidentiality. So either a better explanation of what confidential meant, the way that she was saying it, which is we don't have to loop mom into whatever you're saying, and also having maybe a better explanation of why we would be calling for external resources. Because if you're in a trafficking situation, the one thing you don't want to hear is law enforcement is about to get involved. That's pretty ingrained in what you learn. So we've now really tripped off the fear alert probably for that patient. And so maybe being able to explain that what the fear might be coming up for that patient could have potentially saved that from being a runaway situation.
Thank you, Carrie. So now we're going to talk a little bit more about some of the signs of human trafficking, how we can recognize it, and how as healthcare providers we can respond. So we put up some common health implications that you might see in a victim who has experienced human trafficking. Some of those were signs of physical abuse or unexplained injuries. This looks like cuts, bruises, burns, or just injuries that may be inconsistent with the story of why they are there. Certain neurological conditions, this may look like memory loss, different cardiovascular or respiratory issues, gastrointestinal conditions, dietary health issues. This may look like sleep deprivation, malnutrition, different reproductive issues. This may look like reoccurring STIs, unwanted pregnancies, substance abuse disorder, or other related health issues. So we want to move more into recognizing the signs of human trafficking. So there are two main methods where we can begin to recognize the signs, which are going to be poor mental health or abnormal behavior. What this looks like are a variety of mental health concerns, whether that be depression, anxiety. A patient may present as being tense or paranoid, and general behaviors that don't align with an injury or complaint. And then on the physical health side, we talked a little bit about this in our health implications, different injuries, bruises that are just inconsistent with why they are there, as well as those mental health aspects. And we want to note that while a patient may be coming in presenting with signs, this doesn't automatically mean that human trafficking is occurring, but it's just a sign that it may be an opportunity for intervention, and we may want to go forward and ask these questions. Some more common signs that human trafficking may be occurring is not in control of identification, and we just saw that in the video where the doctor had a concern that the patient was 18 and didn't have any ID. Not being allowed to speak for themselves. We saw that in the video as well. Unable to clarify their address and where they're staying. We're going to talk a little bit about this more when we talk about some questions that we can ask patients that we're seeing. A lost sense of time, unsure about their whereabouts or what city they're in. And then again, those inconsistencies in their stories or things that just make you question their story. So when we talk about human trafficking and interacting with the patient, we're going to be referring to the peer model today. The peer model speaks to how we can communicate with our patients by providing privacy, education, asking questions, respecting them and their boundaries, and responding. So as we talk about the peer model, we want to talk about how we can, sorry about that, my Zoom was moving all over the place. We want to talk about how we can give patients privacy. We want to, when these topics come up and when we begin to screen our patients, we want to discuss sensitive topics alone in a safe setting. We want to separate them from anyone who may be causing them harm and give them opportunity to speak to us in a place where they feel safe. We want to let the patient feel in control of their disclosures. We kind of want to let them guide the conversation and reassert the power in them. We want to educate them by giving them information in a manner that's not judgmental and normalize the sharing of information. What this means is that we want to remain in a place where we're non-judgmental when we're asking questions that promote just the safety of the patient. And we can get creative in the way that we're giving them information. Maybe if they're presenting signs, we can give them a brochure or pamphlet. There are certain institutions that have information maybe on pins or maybe on a keychain. So the way we give information to patients, we can get creative with it. When we ask questions, we want to allow open discussion with the patient. This may look like asking them, is there anything that you'd like to share with me? Is there anything that I didn't ask that you feel as though you want to tell me? Just really, this is where those screening questions come in and allowing them to come in and interact with us. We want to respect the patient and respect their decisions. If a patient denies victimization or declines assistance, we always want to respect the patient's wishes. And then we want to respond. So if we still have ongoing concerns about the patient's safety, we want to offer them resources, whether this be local resources or national resources. We want to offer them maybe a hotline card or a number to an advocate. And then in the case where the patient does accept assistance, we want to arrange a support person to come in, whether that be an advocate. If we're in a hospital, maybe it's a hospital social worker, someone that we can have come in at that time to provide direct support to that patient so that they're cared for after that initial interaction with the healthcare provider. Carrie, is there anything that you'd like to add?
You're all good.
So now we're going to get into some of the more, what I call the nitty gritty and having those difficult conversations with our patients. Before we get into some questions that you could potentially ask, I'd want to ask, if you suspected that you had a patient who might be experiencing human trafficking, what are some questions that you might ask them? And again, you can drop it in the chat or come off mute, whatever makes you more comfortable.
If they're maybe not like a minor, but like an adult, you can start by asking them maybe like, oh, what do you do for work? Or just like kind of quite casual questions to get to know a bit about their daily lives.
Maybe you can ask like about their friends just to see what they say, because if they're being trafficked, then they're obviously not spending time with their peers.
Those are both really good suggestions. Asking casual questions just to get a feel of what their everyday life looks like, and then asking about their friends to find out if they have a support network. So those are both really good questions. Are there any others that people think?
I think also if you can try to slip in like a pop culture reference, like, oh, did you see the new episode of something like last night or whatever? I feel like a lot of those who experience human trafficking, like, they're cut off from the world. So if they say like, oh, I don't watch TV or I don't use social media, that might clue you in that they don't have access to any of those things.
That's also another really good point of just asking questions about relevant issues that someone who is in captivity may not have access to. So that was a really good point, a really good question. So on screen are some of the common questions that you may see in a human trafficking screening. I might have to do some work and add some of your questions to my slides, but some of the common questions that you may see are questions like, where do you sleep and eat? Do you live with other people? Is your family nearby? Are there any doors or windows locked that you can't get out of? Has your ID or documentation been taken from you? Have you been denied food, water, sleep, or medical care? Have you been threatened if you try to leave? Has anyone threatened your family? Have you been physically harmed in any way? And are you being forced to do anything that you do not want to do? After looking at these questions, I wanted to take a brief pause and ask if any of these questions are questions that you might be hesitant to ask, and if so, why?
I think maybe the ID or documentation one, depending where you work, a lot of victims might be undocumented and they don't want to address the legalities of that.
Very true. I think that there are a few that resonated with me. One was that ID and documentation, especially if I'm a healthcare professional working in a diverse environment. I may not want to ask for ID or documentation. If someone comes in during intake, they don't present that. I may feel like that there are underlying barriers as to why they don't have their documentation. Another one that I felt like if I was a healthcare professional, I might not ask is maybe a question of, where do you eat and sleep, or do you live with other people? While these may seem like common questions, a healthcare provider may feel like it's not their business, and that's a completely fair opinion that they may have. So as we're asking these questions, we just want to be mindful to our patients and explaining why we're asking these questions so that we don't come off as being invasive, and letting them know that we do screening as a routine process. Again, when we're in our interactions and we are speaking with our patients, we want to remember, relating back to that peer model, to remain non-judgmental. We want to be aware of our body language and the body language of our patient and who's accompanying them. We want to remember to use plain language and always explain why we're doing things and how we're going to do them. We definitely want to find a professional interpreter if necessary. Through this, we want to work to build a trusting rapport with our patient, and we want to remember to document our concerns, just in the case that this is a recurring patient. Maybe the patient comes in and they present some signs, but we're not really sure. And then the next time they come in, they're continuously presenting signs. This may be something that we want to become more aware of as we interact with our patients over time. So here we want to talk about how we can respond with care when our patients are presenting with signs of human trafficking. We talked a little bit about this in the last few slides, but we want to remember to give clear instructions. This is describing what will be touched, why we're touching them, and notifying the patients before we shift focus from one area of the body to another. We want to establish signals for examination or treatment to be paused, slowed down, or stopped whenever necessary. This is where we talk about relating back to the peer model again, giving the patient that autonomy and respect, asking them to let us know if they want to take a brief pause, letting them navigate the experience. We want to encourage them to ask questions throughout the encounter, and for us to ask questions as well, just creating, again, that safe space for the patient. We want to allow time to help individuals understand what's being asked and why. If it seems like a patient is in distress, we don't want to re-trigger them or re-traumatize them, so we want to move on from topics that may seem like it's causing them distress. And then again, back to that ask and the peer model, throughout the interaction, we want to just check in with our patients, asking them if they're comfortable, what we can do to make them more comfortable. Then we want to monitor the patient's body language and be aware of the trauma responses, which are fight, flight, fawn, and freeze. So if we see some of these things presenting, just being aware that this may be a trauma response. We want to inform our patients if something during that interaction with the patient may be uncomfortable. We want to let them know ahead of time, and we want to avoid false assurances that may be dismissive to a patient's experience. This may look like, oh, don't worry, you'll be fine. It may hurt a pinch. All of these are not reflective of the patient's experiences, so we don't want to give them false reassurances. And then going back to the peer model again, we just wanted to talk about reporting human trafficking. So it's important to use a survivor-centered approach when we do encounter survivors of human trafficking. And it's important to note that not all survivors will be ready to seek assistance, or not all survivors will want to report. Carrie talked about it earlier, how the thought of law enforcement may be extremely triggering to survivors and may initiate, again, that fear tactic. So we just want to be mindful of this as we are interacting with patients. And in most cases, we want you to know that as a healthcare professional, you cannot force an adult survivor to report a crime. and that human trafficking reporting mandates may vary from state to state and by institution or office or hospital that you're working in. We did want to note that, however, if the victim is a minor, that the provider is legally obligated to contact Child Protective Services, and they can help you navigate that reporting process if the victim is a minor. And
I have
then
a question.
Yes, of course.
What if their status of a minor is undetermined?
Can you repeat that?
Yeah, what if it's like this girl where we're not sure if she's a minor or not? Would you still report it?
So yes, with an asterisk, right? So one, we can reach out to, and like perfect timing because we just came to this slide, right? So one, we can just call the human trafficking hotline and ask some hypothetical questions about it. We can also call DCP&P, so that's Child Protective Services here in New Jersey, and present it as that hypothetical and say, we don't have confirmation. Here's why we suspect they might be underage. And then they can also move forward with the information that you give them. So it is okay to, I always say it's okay to call DCP&P and say, I have a hypothetical first, and see if they say this is reportable or not, and then move forward with that information.
Thank you.
And that connects perfectly with our resources. So we put together a few resources for both service providers and survivors who may be experiencing human trafficking. The first is the New Jersey Human Trafficking Hotline. This is a service both for survivors of human trafficking and service providers. So service providers can use this number to report tips of human trafficking. So if something presented in the hospital, we can call that into this number, and they provide access referrals. If we want to provide this patient further help, but we don't exactly know where to turn, we can contact this as well. They also provide a 24-hour hotline for survivors and give survivors direct access to different resources. The New Jersey Human Trafficking Services Dream Free. So this is a 24-hour hotline. This hotline is specifically for survivors of human trafficking or someone who may know a survivor of human trafficking and want to help them navigate that situation. And then the third resource on screen is going to be the National Human Trafficking Resource Center. This one can be for survivors as well, but as just navigating the site is not exactly the most survivor friendly. So I would recommend this one more so for service providers looking to provide advocacy services or looking for referrals or to report human trafficking. And then that just about wraps us up. At this point in the presentation, I'll just open the floor up to any questions. Again, you can come off mute, drop questions in the chat.
Thank you, Kayla. And I know Carrie just put in the NCE sign-in, but if someone missed it, it's in the chat.
I'm also going to add, so not a question, but something I had just read about, which is, and I'm not sure if you all heard about it yet, there was a case at Sarah Lawrence where a father of one of the students there actually moved in with some of the students, and it led to him engaging in sex trafficking with some of the students at that school. I bring it up because a lot of times we feel really removed or disconnected from this, and the reality is it happens around us in places you don't expect. I'm going to see if I can find the link to the article because it talks a lot too about from the perspective of the people who ended up being trafficked. And how they were essentially groomed by this person who just had a very charming personality and integrated himself into their lives. that a lot of times that's what it looks like, right? It's not a very nefarious thing that seems really disconnected. It is a thing that happens, and later afterwards, after a person is able to get out of it, that they get to a place of like, wow, that is really what happened to me. So I wanted to maybe throw that perspective in too, if you have any questions of it, of like, we are more attached to it than you would think we are.
And then I know that Carrie dropped the NCE link in the chat, but if you wanted to scan it via QR code, I have it up on screen for those of you who haven't gotten a chance to fill that out yet.
So this was, he moved in, you said? With like the students? That's
Yeah, so I mean, and the daughter was sort of helped him in that process, but essentially said, my dad doesn't have anywhere to stay. Can he stay here for a little while? And he essentially stayed for a very long time and like integrated himself. And they essentially looked at him like a friend, a father figure, a mentor. And then it got to the place where they were feeling like they were obligated to owe him money. And he suggested ways in which that they could earn that money. And so that is how that relationship built. It is a really interesting story, but right, it starts from such an innocent place of like, hey, can my dad stay on the couch for a week? And you say yes, and it leads to something like that.
Carrie, where was this?
So this was at Sarah Lawrence. I think he actually just got convicted, and I think he got like a 60-year jail sentence. So he had already been in trouble with the law many times over, but I think this was his final bow out in public.
And actually, since we're also on the topic of healthcare, this is not specific to human trafficking, but I know the trauma team at Robert Wood is working on almost a quality improvement like research project, but it's been implemented for the past couple months, where they're trying to integrate more like sexual trauma screening questions. So if any students interested, let me know. But I think the point of that one, of which we discussed here, is also just kind of like, you don't know who's going through it. So kind of trying our best to integrate these questions and normalizing them as part of our routine screening is, I think, hopefully going to be a more efficient way of finding those people who are, those yellow flags that, or maybe even you don't see any flags, but just asking a simple routine question can lead you to that. So, it's like happening at our hospital. So it's good to hear that it's not just like a few places that this is going on. Like I'm glad to hear that changes are being made as we move on.
And it's nice that we can, some of these screening questions, depending on the way they move, right? But some of them are broad enough where it says a simple, like, do you feel safe at home? Which could apply to so many different things, which is wonderful, because then you can have the conversation to really determine what it is that's happening and how it's connected to their health and well-being.
Right.